Thank you, thank you, thank you. Well, it's a real honor to be here with everyone today, virtually, the world as it is. I'm Sylvia Missoula, born and raised in Uruguay, South America. I'm in the US now, work of New York City. I'm an associate professor of psychology, criminal justice. My research focuses on racism, discrimination, particularly with South American, Central American communities living in the United States. It's my pleasure to introduce Dr. Charles Branas, who is the director of the Center for Injury Science and Prevention. He is an endowed professor of epidemiology, the chair of Columbia University's Department of Epidemiology, and an elected member of the National Academy of Medicine and American Epidemiological Society. Besides being a pioneer research on healthcare access, place-based interventions of gun violence, he has led multinational efforts producing extensive cohorts of scientists and national health metrics. Dr. Charles Branas. Now it's my pleasure also to introduce Dr. Milton Weinberg, who's a professor of clinical psychiatry and director of mental health wellness equity center at Columbia University, New York State Psychiatric Institute. He is the director of an NIMH-funded Columbia University Global Mental Health Implementation Science postdoctoral grant. He's the director of the NIMH Fogarty International Funded Portuguese-speaking African countries Mental Health Implementation Research Training Program. He's the co-director of another internationally funded capacity development in HIV and mental health research in Asia. Wow, I will keep going because this is amazing. He's a founding chair of the Caucus of Global Mental Health and Psychiatry of the American Psychiatric Association and medical director of the Columbia University HIV Mental Health Training Project. His research focuses on global mental health implementation science and the intersection of HIV prevention and care with mental health and substance abuse among diverse, vulnerable populations in the United States and globally. Welcome to you both.
Thank you.
Thank you so much. Wonderful, thank you.
Thank you very much. And for the introductions. Milton, do you want to go first or do you want me to?
You're the boss, you tell me.
Am I the boss? Okay. Well.
Yeah, you're the chair of epidemiology, I'm not.
All right. My last name is alphabetically first, so I'll take the stand.
Okay.
I just want to, first off, thanks, Dr. Missoula, for the wonderful introduction. It was very kind of you, and thanks for all of you who are here today. I think what Milton and I are going to talk about, that we've briefly had a chance to interact on via email, is our connection to prior NIH training programs like the one that is now being launched in Guyana. And if it's okay, I'd like to share my slides, if that's, I think that's functional. And I want to talk to you about programs that that I've been part of and have led in the past. And this, maybe it'll be of interest to Dr. Missoula, because we've really focused quite a bit, and I want to talk mostly about our work in Central America, because I think from a Fogarty standpoint, Central America and aspects of South America, much like Guyana, have been somewhat forgotten in the NIH's mindset. So let me just see if I can do this. So I'm going to tell you about a couple of programs, and then we're going to talk for maybe, Milton and I will each talk maybe for 10, 15 minutes. And then we're hoping to have a conversation with anyone who wants to ask any questions from there about this program. And I think there will also be a conversation tomorrow about the new Fogarty program in Guatemala. And I should just frame this by maybe saying what the Fogarty International Center is at the U.S. National Institutes of Health. And for those of you who don't know, the NIH, the National Institutes of Health in the US, is the largest scientific funding agency on the planet. And they obviously fund a lot of projects, but they also fund a decent amount of training the next generation of scientists in the US, and in fact, a number of places around the world. Now, the I in NIH is institutes plural, right? So there's more than one institute and center in the NIH. It just so happens all the institutes have their own global health focus. For instance, there's an institute on mental health, and it does have a global health focus. But there's one center in the NIH that basically is the home for global health at the NIH, and that is the Fogarty International Center at the NIH, which is often abbreviated as FIC. You may see that in my slides coming up. It partners with many of the other much larger institutes to do work and to mostly fund capacity strengthening in nations around the world, exclusively in nations that like Guyana or Guatemala, which I'm going to talk to you about, or Botswana. It does not fund training programs in nations that are the highest income nations in the world. Those are not on the list for the Fogarty International Center. So the work I'm going to tell you about, and we're going to go through, I think there's going to be a presentation on the specific Guyana program, but we thought we'd tell you about some of these prior programs. I'm going to tell you about a program that I was part of beginning at the University of Pennsylvania in Philadelphia here in the US as a partner program with the country of Guatemala. This led to a number of other NIH Fogarty International training programs, including in the country of Botswana in Southern Africa. I'm going to just tell you some of the components of this program in Guatemala mostly, and sort of how it might serve as a model for what we're going to do. Aspects of it may serve as a model for what we might want to do in Guyana. Of course, whatever happens in Guyana will be entirely up to the country, and it will need to be tailored specifically. So these other country examples are not going to dictate what happens, but they're nice to know about of what's happened in the past. So we formed probably in, oh my goodness, maybe in 2008, the Guatemala Penn Partners, which was a partnership between myself and these two other gentlemen here, Sergio Martinez and Erwin Cagua, who are part of two different universities in Guatemala. The work in Guatemala subsequently led to work to create the Botswana UPenn Partners, but I'm going to focus on Guatemala, as I said. And I'm going to talk today about the program itself, some of the lessons we learned, and then what the future held for the program, and continues to hold, by the way. So one important thing to know about Guatemala and the University of Pennsylvania, and you all can hear me just fine, right, Milton? It's okay? Yeah, good. There is a century of connection between the university and the country, beginning with co-excavation between Guatemalan archaeologists and archaeologists from the University of Pennsylvania of the temples, multiple temples at Tikal in northern Guatemala. So you can see one of them here that was co-excavated. This is, I think, Temple 5. And if any of you have been there, it's quite magnificent, ranging on up to, for those of you who don't know, it was probably the greatest, if not one of the top two greatest bioethical violations in the history of medicine and public health, was the experimentation with syphilis on Guatemalan prisoners and citizens from 1946 to 1948. And this really didn't come to light. It came to light, I'd say, less than a decade ago. A pretty diligent historian at Wellesley College pulled it up and brought this to light. And in fact, it led to the creation of this Presidential Commission for the Study of Bioethical Issues in Guatemala, and a formal apology from President Obama to the President of Guatemala at the time over this issue that was sanctioned by the US government and was led by the Centers for Disease Control, and just a horrible, horrible situation. Many Americans at least know about the Tuskegee syphilis experiments. and the horrible bioethical violation there. This is effectively one level above that. So there was a formal apology between the countries, and the president of the University of Pennsylvania of the university led this commission. So it's just a way of saying there's a long connection between the country and this particular university. The entire Guatemala Penn Partners program was built on a couple of basic principles and led to a series of different products. The first principle here is that we had connections as the most basic connections were between universities, and then non-governmental and governmental partners at the highest levels were then brought in. But the foundation was university-to-university connections. The universities and all of the partners retained all of their autonomy. And the idea was that there would be locally led capacity strengthening in Guatemala, which was the absolute primary goal of all of this partnership. And that the exchange would be mutually beneficial and bilateral. That is, the hope and the accomplishment here was that the University of Pennsylvania would learn as much from their Guatemalan partners as those Guatemalan partners would stand to benefit from the University of Pennsylvania, and that there would be a two-way street. The program itself had a scientific product, and that is creating these independent investigators, independent scientists, as well as a series of associate scientists, and training them in many different things, including the responsible conduct of research. But we also had a lot of work in terms of a couple of medical specialties and a global health fellowship, in terms of healthcare education. And then in terms of public health, we also formed the Guatemala Health Initiative, which still is very strong today, continues, and has built a small hospital. Actually, it's not that small, a mid-sized hospital in rural Guatemala to serve that area, as well as other field schools and other training opportunities that are there as part of this. And those remain to this day. All of this remains to this day. The university-university connection was, we wrote a book about it. It was called Meeting in the Middle, and it was basically the way the University of Pennsylvania served to bring together two very different Guatemalan universities at the time. The one is the University of San Carlos, which is a university, it's pretty fascinating differential. It's a university effectively founded on Marxist ideals. A large, very large public university, for instance, the medical school, which was our primary connection, carries 5,000 medical students at any point. And we bridged this with the University of Francisco Marroquin, which was effectively the complete opposite. Is a university that's built on capitalist ideals, and in fact refuses to take any governmental money because they want zero connection with any government anywhere in the world. And it is all based on capitalism. So the University of San Carlos is effectively built around its medical school and its School of Engineering at some level, is a massive institution. Francisco Marroquin, UFM, is much smaller and is effectively built around its business school. So part of this was bringing these two partners together, which had, each of them had quite impressive contributions and connections to make to the Guatemala Penn Partners. The other thing I will say is that I'm going to talk mostly about one of our training programs, which is really focused on injury prevention. I know we're focusing on mental health a lot today, but we are also focusing on suicide, and suicide is an injury and is something that injury prevention specialists really focus on. And whether you know it or not, injury is the #1 global health threat in the first half of life. So before the age of 45, it's the #1 threat to children and young adults, and in fact, to developing nations. And this was an article that was written in 2008 in the New England Journal that was really intended to raise the viewpoint globally of the burden of disease for chronic disease. But in fact, it really points out that injuries are a massive disability burden to the world. And that there are it's up to something like 5 million deaths each year globally due to injuries. And injuries here we define as unintentional injuries, things that happen by accident, or intentional injuries, things like homicides and other acts of intentional violence, as well as, by the way, suicide, which is an intentional injury, is intended to be done that way. And then other accidents include motor vehicle crashes, as well. So if you add all these up, it's something around 5 million deaths per year, which is actually more than malaria, HIV, and tuberculosis combined. So this is a massive burden for the world. Guatemala itself was a particularly challenging situation. The country remains actually. If you take what's called the Northern Triangle of Central America, it was Guatemala, El Salvador, and Honduras, and the three combined actually have more violence, particularly homicide, than anywhere else in the world outside of active war. And part of this is that these countries have been going in and out of civil war for so long. Guatemala actually had one of the longest civil wars in world history at 36 years. And this led to a lot of different problems, including a lot of issues with an excess number of weapons in the country, and then other issues. So basically, the country's two biggest issues were interpersonal violence, including from firearms, as well as intimate partner violence and motor vehicle crashes. And these are two things that our programs very much funded by the NIH focused on. One of the challenges about violence in Guatemala is that it has been going on for so long, quite frankly, that it has been largely normalized in the country. And this is a cycle that goes on in a lot of nations around the world, where nations' poverty drives investment in things that are not helpful, like military, that then create weapons are built to a great degree. The country falls into civil war. The weapons leak to various individuals who should not have them. And that, even when the civil war ends, that leads to everyday violence like homicide, and the cycle continues. That homicide then drives civil war again. And in Guatemala, the cost of violence is extremely high. It's something around 7% of their gross national product that is invested in dealing with, frankly, with homicide in the nation. And so this is really quite a challenge. And when I say normalization, I mean it has crept into the way people pursue their daily activities. For instance, in Guatemala, you rarely see an automobile without windows blacked out because people do not want to be seen in their cars, as one example. And it's led to a lot of industry for automobile makers who can make blacked out windows, but it's also led to other unintended consequences that are not the violence. For instance, people can't see well while driving at night in a car where the windshield that you look out of is dark black, and crashes have gone up. So there's a lot of issues that have gone on with the normalization of violence, and it was one of the things we very much focused on. So some of the program goals is we wanted to create independent and extramurally funded researchers in teams that also included supporting researchers to strengthen research in that capacity, to address their priority national trauma and mental health issues that had accompanied this normalization of violence, and in fact, to produce institutional and national leaders in public health and in epidemiology. I would say we did this. In the end, after all the training programs were done, specifically for injury prevention, we trained somewhere along the lines of 60 plus, 65 plus investigators. 13 of them were these very highly trained independent investigators who were in the country and doing what we call cross-country training, cross-national training, meaning they would come to the United States, to the University of Pennsylvania and elsewhere to get portions of their training, and then return to Guatemala to finish their training in clinical research and epidemiology and public health and statistics. They applied their skills, as I said, mostly to injury and violence as well as mental health care. And the program was one that was completely funded with a tuition share between the US federal government and the university. And then the country of Guatemala, in the interest of mutual exchange and bilaterality, through the vice president's office, did then have, after they finished 2 years of training, extended a stipend for an additional 2 years of protected time to these individuals, so that they could return to the country and not be taken away for instance, specialty medical care or something like that, that they really could focus on public health as a career choice. And then in addition to those 13 highly trained folks, we had another 54 that were trained only in country through summer programs. and receive certificates of training at the end. And you can see some of the pictures here of our visits to Guatemala and the connections. Here are the two universities, one at San Carlos and the other Francisco Marroquin. This is one of our first trainee getting the Global Health Award from Lancet. And these are our other various trainees, Guatemalan trainees that came to the University of Pennsylvania. And then I have to say these bottom two pictures are very important to me because these are University of Pennsylvania students visiting Guatemala. And I normally don't show pictures of people from the country. We do have permission from these folks, these local Sutuhili Mayan women, to show their picture. And I think what was important is that they effectively adopted our US students and brought them into their families. And the students you can see here, this is our Penn students, not simply doing research, but this is them building the hospital that I mentioned before. So we're very, very proud of them. And this is, of course, a decade ago where they started that. So we had a number of projects related to violence and mental health. And in fact, in the spill out of the Civil War that were at the direction of the nation's leaders, including nationally, but also many local leaders. We had a number of different things that were in rural areas of Guatemala, where we would have local Mayan leaders who would be giving guidance on what they thought was important to study and so forth. I'll pass over this. This is one thing a very prominent thing that we published on the mental health consequences of the Civil War. No one had studied this, and this was of great value to the country and beginning to make, and really did change investments in the mental health system there, which had been seriously underinvested in. My goodness, for decades and decades. And this was something that we did, well, that they led, right? The Guatemalans led this because this was the first national mental health survey in the country that was led by their Instituto de Estadística, their National Statistics Institute, led this national random sample to represent the country for mental health. And it led to findings that for the national leadership, including at the level of the president's office, that they had not yet seen. And so it was of great value here. So what does the future hold? Well, I think the future holds still and held. The scientific capacity strengthening is continuing in the country. In fact, with this, so we have this program in Guyana with Colombia and the Fogarty International Center at NIH. In fact, in the same group of grants that were funded is a continued capacity strengthening, scientific capacity strengthening for Guatemala with Drexel University in Philadelphia. So this will continue, and the network there will continue to be built. And basically, this investment has also led to sustained government investment on behalf of Guatemala at the president level of the president's office, but also from the Guatemala, the equivalent of the NIH in Guatemala is now a large partner that is putting money into continuing the programs. And then the investments, as I said before, from the NIH and in fact, the US Centers for Disease Control continue in Guatemala over this, in injury prevention, but also in issues of bioethics and HIV/AIDS. And then I have to an important point that I'm hoping we're going to get to talk about a little more is the importance of global South-South connections that were started here in Guatemala. For instance, Cayetano Heredia, which is a university in Peru, a very old and important university in Peru, which is quite advanced scientifically, effectively is just like Colombia. Scientifically has a very impressive medical school and school of public health. They were really a key partner in connecting with our Guatemalan universities. By the way, as was OPS, or the Pan American Health Organization, was also quite important in connecting with our Guatemalan partners. And in fact, two of our trainees went to work for PAHO in Guatemala, which is and I think one of them continues to work for PAHO in Guatemala. So that was a really important connection. So the future really is about, the real future is about our graduates. We do feel like we trained epidemiologists in a country which at the time had very limited infrastructure in terms of epidemiology, very, very few, if any, epidemiologists. The mentoring and the program strengthening continues. And in fact, a number of our trainees have gone into leadership positions and even political positions And the network of epidemiologists and public health professionals that we've created there has continued to this day and was of incredible value. So I'm going to end with this slide. Was of incredible value at the time of the pandemic for a nation that perhaps had one or two epidemiologists to now have dozens. Those epidemiologists who trained with us and the epidemiologists that they then trained were front and center over the course of the pandemic in Congress in Guatemala, in the president's office. And in fact, you can see here the president of the country and one of our trainees, Erwin Cagua, who is here in his biosafety suit. But Erwin led basically the pandemic response on behalf of the country. And I also have to put a shout out. This is Victor Puig, and this is Alejandra Paniagua. Victor is our very first trainee in the Guatemala Penn Partners, and Alejandra was our last trainee of all our trainees. And they subsequently both came to Colombia to finish their training in epidemiology before returning to Guatemala. So it's just wonderful, and thanks very much for the opportunity to say something here. And I sort of look at this progression as something, my hope is that we're going to do something different, but equally impactful in Guyana. Thank you.
That was wonderful, Charlie. And we have a few things in common, and hopefully I'll be able to. So let me share my screen so we move directly. I hope that it's showing properly. So I'm going to be talking about mental health implementation science in Africa and Asia. And let me take and training the next generation. This is going to talk about 3 different grants. And these are all the collaborators. You have the first 2 rows are people from Universidad Eduardo Mondlane in Mozambique and the Mozambique Ministry of Health, which has been very important. Then Jair Mari in Sao Paulo, Brazil, for the South-South collaboration, Charlie, that you were just talking about. We're also in Asia with an Exxon and Amfer. And then Maria Oquendo has been a sister in all of this, that now she's at UPenn. Charlie, you came and she went there. And then I'm at Columbia. So let me start by talking about why mental health. And this is very important because the 3 studies, the 3 grants that I'm going to talk about are, the value of them is that it's about looking about implementation science, which is to bring the research to practice, to create solutions to treat what's taking place. So I know that Charlie talked about injuries. He talked about them as risk. This is a different way of looking at the burden of disease, that it's talking about years lost with disability, and mental disorders in the 4 continents are number 1. And with regards to the DALYs, which adds the years of life lost, it's between 1 and 2, depending on the continent. So mental and substance use disorders are the leading causes of disability worldwide across both sexes and entire lifespan. And we also know that people that have mental and substance use disorders, poor physical health, have an average life expectancy that it's 15 to 25 years shorter than of the general population. And the poorer the country, the more years of a shorter life people with MS disorders have. So this is just very quickly to talk about the mental health treatment gap, which means who needs help and who gets it. So in high-income countries, between 35 to 50% of people get care if they need it. In low and middle-income countries, it's between 76 to 85. So it's really bad. And I'm not going to, this is a slide where I try to summarize why evidence-based treatments are not being used in either low and middle-income countries or high-income countries. And as you see are science-level factors that are related to epidemiological data, having measures to use that their evidence therapies for efficacy or for effectiveness or for implementation, and for more than one disorder at a time, which is also quite important because we tend to talk about mental health and most of the studies perhaps do depression, whereas there's a variety of psychiatric disorders. There are health systems factors, which is, do they have clinics, do primary care and other services provide mental health care? Are psychotropics available? And as you can see, 4 is high and 1 is low. As these move along, as we go into this, lay personnel is terrible in high-income countries in comparison to some of the things that are happening in low and middle-income countries. So we're training community health workers to do things. And definitely issues of funding are complicated everywhere, worse in poor. So this is to show that low and middle-income countries are in terrible shape, unfortunately. But we're not doing that great in some issues in high-income countries. So the problem is vast. So our work is in dissemination and implementation science, which is how do you make sure that research, evidence-based interventions go to practice in real-world health systems. So what has happened so far, even in high-income countries, that even if we train people to do evidence-based treatments, we train them to do private practice. It doesn't go into the health system. And so the idea is to identify, understand, and overcome barriers for adoption, adaptation, integration, and scale-up in a sustainable way that you have evidence-based interventions. So implementation is how you create an active approach to integrate them, and dissemination is an active approach to spreading them. So the word active is because we in science tend to do publications and conferences, and we know that that is not changing, not even in high-income countries where the uptake, as I showed, was really bad. So for the adoption and uptake of evidence-based intervention, we need to have active strategies to introduce them to make sure that they're used. And that is the goal of all of the training grants that we're going to do. So my story started in 2012 when I created the first global mental health implementation science postdoctoral research fellowship at NIMH in a T32. I've had fantastic fellows that I work with and I learn from. And the idea was to do deployment-focused intervention research to adapt evidence-based interventions ready to be implemented with community collaboration and address the needs, prevention, recognition, assessment, and treatment. And the other focus is how do we do dissemination, implementations, and services, and to bridge the gap for this evidence to be used within systems of care. And the question here is global versus local in the US, and low and middle income countries are definitely our focus, but we also work in low resource settings in the US. So these are the wonderful fellows that I've had so far. And as you can see, there's some of them working in Mozambique because we have a strong force there that I'm going to talk with you about. As I mentioned, the D43, the very young Asia program that I'm going to talk about is yet in the process, but we're getting there. So the same way that we talked about the global mental health treatment gap, just as Charlie was saying, the research gap can be enormous, and less than 10% of health-related research addresses low and middle income countries where 90% of the population lives. Researches and publications concentrated in 10% of the countries. And the mental health of the work is less than 4% of the health literature, and it's much worse in low and middle income country. And one of the elements that we also know that the burden of disease that I've been talking about, we now have more evidence, we have more activities, more things happening, and it has not changed since 1990. So all of the efforts that have been put so far have not created a change in the treatment and research gap as we're talking about. So I always like to explain the traditional model without insulting anybody, and I hope that nobody gets offended. We used to think very colonialistically, which is we researchers in the high-income countries, and by the way, I'm from Venezuela, and I hope that the people in Guyana are not very upset with me that I'm from Venezuela. Our goal is to, we knew, and we would go to places and we would do either the conceptual framework of each culture is unique, or we do epidemiological studies using measures that we adapt. And then there's the methodology that is more qualitative on one hand or quantitative. And then the training happens to be anthropology or sociology versus epidemiology. In global mental health, we've created a new partnership model where I don't know more than them. They know more than me. They live there. They are the people who know more about the place. So this is about working together in bidirectional learning and knowledge generation. And Charlie spoke about that in his work too, is to create an integration using mixed methods. We want to make sure that we do qualitative and quantitative and is interdisciplinary. So it's a long-term ongoing engagement across the phases, and the high-income countries are no longer the sole expert, and the emphasis on sustainability. So our first D43 Fogarty started only recently in 2014. And these are the people who are currently the PIs. And we started working in 3 of the 5 Portuguese-speaking countries. Unfortunately, in Cabo Verde, there's like 1 psychiatrist. In Angola, there's 1.5 because there's basically no mental health. And then Mozambique is, from all of them, the one that had at least some potential, that had some issues, some abilities to do some mental health work. So even in Mozambique, that is the 4th poorest country in the world, it did better than other countries where there was no mental health. And Brazil, collaborator, and USA, collaborator. So Mozambique has a vast mental health and treatment research gap. It has 29 million people, 18 psychiatrists, and no PhDs. And that we figured out we needed to also work and change. So very quickly, our program, when we started, we had senior level faculty who were not mental health people because they're already in research, but more in the areas of HIV and cardiovascular disease. Then we had fellows that are mid-level faculty that we wanted to train them for the future, and junior faculty. And we also wanted to do trainer of trainers of evidence-based intervention. So you have established researchers, psychiatrists and psychologists from universities, medical school or involved in MISAO, is Ministry of Health. And we also wanted to work within the system of care. So we did didactics first to make sure that we engage senior people to work with us and within mental health because it was not their expertise. Then we work with our fellows, which were, and as you see, that our goal was to create 9 PhDs and 2 masters. We're in the process of doing all of that. And the idea is that's always training and supervision. And we wanted to make sure that we start using evidence-based treatment. So the output has been to train the Ministry of Health providers. And we are now doing the shifting with where we're training 800 people. We created a cadre of mental health implementation scientists that are working with us, who are mentors. And together with the senior, we have developed pilot studies. And the pilot study started with perinatal depression, HIV and depression, a small pilot project. That one of them became very big because one of our fellows, Lydia Gouveia, was in charge of the Ministry of Health in mental health. So she could not come up with a little pilot. And I'll talk to you a little bit about it. And then for the follow-up, the renewal that we already have, the idea is that these individuals become the new faculty and PIs and policy. So we don't have any fun when we do our work. And based on the work that we were doing, we have a very large study in Mozambique that includes also capacity building in 4 other countries, Botswana, Malawi, South Africa, and Zambia. And very quickly to tell you, we've been able to create, and it's only because we work with them, this is a comprehensive mental health intervention, meaning it's not just depression care, it's not just substance abuse care. The idea is to treat everything. 70% of the country has no access to mental health care, including not having medications, because primary care providers are not allowed to prescribe. So we created this study that expands mental health to rural areas, 70% in the biggest province of the country that has about 7 million people, which is Nampula. And the idea is that community health workers speak with the informant in each household, which is the normal way to find out what's happening, who has HIV, are they taking the medication, anybody pregnant, anybody with diarrhea. They have to take care between 250 to 450 families. And we created a measure that with 3 questions, we have 73% sensitivity that one of the household members has any mental and substance use disorder, identification by proxy. Then the person, the community health worker speaks with that person and asks the same 3 questions. We increase the sensitivity for that for 94%. We know who doesn't have a disorder. And the step 3 is by asking 9 additional questions to be able to categorize for acute care or disorders that we know we would have treatment. And we also are looking at social determinants of health to understand what brings about in what we can also change with regards to the social determinants. And this is the electronic mental wellness tool. I have to tell you that it's only that we're working in Mozambique that we were able to do that. We have also global partners in Asia. Annette Son is the principal investigator, and we are collaborating. It's a collaboration between Cambodia, Philippines, Thailand, and Malaysia, and with the United States. And the idea in this one is to do more HIV mental health implementation science, because this is part of AMFAR, which is an organization, and the idea is the Pacific Clinics, that they are epidemiological sites for HIV and mental health. Basically, what we do in both is didactic training, workshops, mentorship, both with local senior and with us and other countries in South-South collaboration. writing methods mentors, research ethics, pilots, grant management training, scientific writing, public speaking, and policy engagement, because for us, sustainability is the most important. We don't want to do anything that gets lost, and networking. And with that, I'm going to stop sharing.
Thank you so much, Dr. Weinberg and Dr. Branas. We're going to open the floor for any questions. Our in-person participants, if you have any questions, please raise your hand. And our Zoom participants, if you have any questions, you can type them in the chat and we'll be happy to answer them for you. Hello?
Yes.
Hello? Okay.
Yeah, go ahead.
You can hear me? Okay, good, good. All right. Thank you very much to both speakers. It was, as we are embarking now here, trying to do training and so on in Guyana, it's good to see that, there are examples of this being done in, I'd say, similar countries, but of course, every country is different, as you say. But I was wondering, I think Dr. Branas had mentioned this, but I wonder if you could basically outline in terms of the lessons learned and this what mainly because we don't want to anything that we don't have to do and that we don't have to learn, well, we would appreciate that. So any lessons learned and the things that you think helped you to be successful in the ventures that you mentioned.
So is your question more of things to avoid?
Yes,
in,
basically.
in our learning?
Yes, thank you. Yes.
And so I think that is a fabulous, very pointed and important question. And maybe Milton has more to add to this. I guess I was scribbling some things down, and one of the lessons that I think we learned early on, so I have two thoughts. So one of the lessons we learned early on was that it's difficult to train people in public health and then not have anywhere for them to land. Public health and epidemiology, the value of the work that's done, the prevention work on a population scale, and not simply the research, but Milton was talking about, very much applied implementation science research. This is work that could have a direct impact in improving health. But for folks to carry that on, there needs to be a structure that recognizes that work is of value, and wants to have a work towards a sustained structure to support that work. And I think in our early days, we did train one or two people who, this is no fault of these trainees, but they would go back into an economic structure where there was simply no work for them. So there was, these were physicians, right? Both of those folks were physicians, and they just, to make ends meet for their family, they basically went into private practice right away. And that then took over their career time entirely. And so what they had been trained to do in support of the nation and at the request of the nation, just wasn't feasible for them to do in practice. And so that was when we began to have meetings. Well, the leadership actually suggested this. We're very fortunate that the vice president of Guatemala was a physician, was actually a cardiologist. And so at his thinking and his team's thinking, they suggested that we raise money to offset the immediate time after training in support of that continued work in what they were trained to do. It's not that they left their clinical practice, but it wasn't the dominant thing that they did. So that's one thought that I have that comes to mind. My other thought, and I'm curious what Milton thinks of this too. I think so I'll put this in a US context. How about that? We spend 20% of all taxpayer money, all our public money gets spent on medicine and the healthcare system. And the vast majority of that investment is in very expensive clinics and hospitals. I think there is a tendency to see that in the United States. And by the way, we make that massive investment and our health indicators as a nation are terrible for that investment. So our return on that investment is just, embarrassingly low. But other nations see that and seem to think that that's a direction to go. So I think in my work in, whether it was in Africa or in Guatemala or Honduras or El Salvador, there's constantly these questions about should we really be investing in this prevention and things that are not high ticket, high profile medical care. For instance, it took us years to do some of the work that would show the return on investment in a very expensive transplant clinic for Guatemala. That single investment in that polyclinic is money that was funded, health posts, puestos de salud around the nation that contributed to good mental health and other things. And so it's this trade-off. And I think people see the United States and think that we're doing it right, when in fact, we're not, and we have a lot to learn. And I don't know why we should be retreading these US errors in other nations.
Well said, Charlie, thank you. So we learned from previous work that we needed to think about this early. For us, our model is policymakers have to be there from the beginning, especially when mental health is so disregarded, right? The investment in mental health, even in the US, is very low. So in very poor countries, it becomes worse. So it was very important to have so by having people from the ministry from the get-go, it was the only way. I remember when I went the first time there, I went to do a training on mental health and HIV. And of course, they know more about me because they have 19% of HIV in the country, where I've been in places where they have 1%. So there was the director of mental health of the country. And I immediately said, do you want to have a coffee, a glass of wine, and maybe 20 years of working together? And it was only because of that is that we've been able to have the strength to do what we have. Also to have the university. So one of the things that we did, Charlie, because of the brain drainage, and actually this came from them, not from us, so this is not my idea. They already had a plan that if you are part of this fellowship, you have to give back 3 years after you finish. Otherwise, you cannot, otherwise you have to pay for the training from your pocket. And this was a university rule that they had, and that was very helpful. For mental health, it's complicated. So I can tell you that in our work, mental health at the university level and other levels, it's not regarded in good shape. It's not regarded as a value. Stigma has an important element here. What we've been able to accomplish is because the director of the mental health program at the ministry was invested in this. And we were able to do these very big things that are changing and will change. Mental health care and access to care and other things. But it's truly including people at the beginning that need to be at the table, because otherwise it's almost like you're competing with everybody else. So I'm not quite sure who's involved in the Guyana work. Involve policymakers, involve people from the beginning on a regular basis.
Thank you so much, Dr. Branas and Dr. Weinberg. We are running a little short of time now. If somebody have any other question, we're just going to take another 2 minutes.
I had a question, a very quick question, really. And so I'm public health trained, but then moved into doing more ethnographic. Particularly, I did work around implementation, but looking at it from an ethnographic perspective and working within communities. And I note within your approaches, where do you see a participatory approach, co-design, co-production, featuring? Because I didn't get a sense of that in terms of working with local communities and so on.
I would say everywhere. Everything that we do.
Everywhere.
We have ethnographers, and every work that I've done, ethnography is like number one. So we include is transdisciplinary, interdisciplinary. We want to hear. For us, all the knowledge comes from the country. I may help. I consider myself the catalyst to put everybody together, and then I learn. I sit there and I'm like, what we've been able to do. We have the first study ever to do comprehensive mental health scale up. And that only happens because they pushed for it. I would have never thought about that because nobody does that, but they needed it and we came up with that and IMH funded it. So we're very excited. So I would say that 90% of what comes in is local.
And that's what you're planning to do in Guyana as well as part of the programs that are planned.
I think part of I'll put that question back to you. It's what you're planning to do. And it's really, I mean, our work in Guatemala that was their work. I mean, every project that you saw was not our idea. It was all partners' ideas. And to the ethnography comment, I talked about building a hospital, but I also had a line in there about anthropology field training. There are 2 anthropology field training schools that were launched as well, led by Guatemalans. And yeah. I want to point out, so I do think the co-development and co-production is absolutely vital. And it speaks to what both Milton and I said about bidirectionality here. I'm trying to give you a good example. Like, for instance, I had a health economist in Guatemala who, before marijuana was being legalized in the US, had done some fantastic work for his country and for Central America, estimating the cost savings from all the violence reduction, frankly, of legalizing marijuana in those nations. That research was passed to us, and we passed it to US policymakers. So as a opposite direction of the value of our partners there, our scientific partners there, informing US policy. So I really do expect this to be bidirectional and fully co-produced. And this is not our issues, our questions. So I think your question is right on. I was going to ask about how to do this more.
Well, just to let you know, I'm doing a talk as well, but I've got a PhD student doing some ethnographic work in Guyana as well, looking at suicide. But it has been a struggle for me working in other parts of the world, trying to get funding to do, particularly in the UK, to get work that is ethnographic, participatory. So it's really interesting to hear from a US perspective how you go about it. So thank you very much.
It's challenging for us too, but we managed to figure out a way to make the mixed methods work.
Absolutely.
Well, I think I'll need to be in touch.
Oh, we're happy to be in touch.
Excellent. I like it.
They didn't have to pull us to do this. We're very happy to be part of this.
Okay, you'll get an email from me.
Thank you for that question. We're wrapping up now, and I just want to end by saying thank you both. And the question that you brought up was actually excellent, because that's what I wanted to comment as my ending comment. It came up for me, the issue of the US or the high income countries are no longer the experts, right? Because for a long time, it just seems like we feel like we know what we're doing. And that is not the case. So as a psychologist and as someone that's social justice focused, my primary interest is not what we think, but what the people think. And we can't even come up with any design, anything, unless the people are involved. And what I mean by people is the people of the country, but also the people that are disadvantaged, underserviced, et cetera. So Milton and Charles, I really appreciate your talk. Very interesting, exceptional. And I do look forward to Penelope making some contacts there. And I wish everybody a great time at the rest of the conference. Thank you.
Thank you so much, everybody.
Bye.
Thank you so much for everybody for taking some time after your busy schedules. Thank you so much, Dr. Mazzulla. Thank you so much, Dr. Weinberg. And thank you so much, Dr. Branas. It was wonderful having you in here. Thank you.
Our pleasure. Thank you.
Bye, everybody.